We're going to spend just a few minutes talking about some other aspects and especially payers' use of healthcare data warehousing. And we've been talking about, storing information, information warehouse, how you use the data. And if you think about, and I'll just refer to them as the functional areas of a health plan, you've got finance. Finance is driving the financial reporting. Financial reporting has to go to the state, the federal, maybe some local agencies. It's also sent to like CMS and state reporting guidelines. So finance is sending a lot of information in a lot of different directions, especially your finance department if they are a finance department in a for-profit organization, and especially those that have shareholders or stockholders. So, finance department is going to use a lot of this information that resides in our data warehouse. Yeah. When we're talking about operations, think about operations, talking about the information in the data warehouse that not only is operations pulling information from the data warehouse, but they're providing information to the data warehouse. Operations, you're talking about call centers, you're talking about claims adjudication teams, anything to do with the mail room, anything to do with the movement of information. So operations, I call them kind of the guts of the health plan, those that are doing the day-to-day activities to ensure that the claims are adjudicating correctly. They are not only using a lot of information out of a data warehouse, but they are providing a lot of information into a data warehouse or an information warehouse. You've got internal audits, you've got risk management, you've got your legal teams constantly utilizing information out of a data warehouse, and not only utilizing the information to determine the accuracy of their audit findings or the accuracy of their risk management processes, or whether they are legally determined to be at risk for some aspect of healthcare. So not only are they utilizing that information out there, but they need a secure location to store their information. So while they may have a standalone information warehouse, they can also have a secure area in the information warehouse that only those teams can access when they need to back that type of information out. You've got medical management, an area that is just constantly determining how to provide a defined or a definitive scope of healthcare goods and services to a consuming population. Medical directors, nurses, ancillary type individuals, constantly in making decisions, making determinations on referrals and authorizations, and should services be denied, and how many days you should be approved being in a hospital, and the number of services that you can be provided from the doctor's office. There's just a lot of activity with the medical management team when it comes to both the determination of access to services prior to the service being rendered, but also follow-up type of information to ensure that the patient or the member receive the highest quality of service and the appropriate service for that particular episode of care. You've got the network management team. Network management team are the individuals that work hand in glove with not only the doctor's offices, but the hospitals. They're negotiating contracts. They're trying to determine if a contract that they have in place is financially viable. They're trying to determine, in concert with medical management, whether certain healthcare goods and services, how they should be priced and whether they should be offered as part of a benefit plan. So you've got medical management and you've got network management almost joined at the hip as they go through the day-to-day activities of ensuring that proper health care is being provided at the appropriate price point to a consuming population. You've got the area that I worked in and managed. You've got payment integrity and risk adjustment. Payment integrity. I had a team that we had fraud, waste, and abuse. We had COB. I had a data governance team. I had an information, medical management, information warehouse, analytical team, data governance. I had a lot of individuals rolled up under that team, and we were trying to ensure that an individual's health care claim processed accurately the first time and every time. It didn't always work out because there were a lot of providers that probably doing things that they shouldn't have been providing for our covered members, providers that were submitting claims that might not have been as accurate as possible. That's why we had fraud, waste, and abuse. But it was a team that again, we tried to ensure for both the health plan and the member that the claim processed accurately as possible the first time and every time it came through the system. If we found instances where it didn't, then we went about our job of validating why the claim didn't accurately, we call adjudicate or process, why it didn't accurately adjudicate and process, and then we would go back, work with the members or work with the providers for the most part, and ensure that that claim was reprocessed and paid correctly the next time through. Risk adjustment, especially you see these types of individuals working with Medicare Advantage and some of your government programs to ensure that the payments that the health plan received from these government programs for providing goods and services to the covered members of these government programs, that they were, that the health plan was being adequately reimbursed from the government agency to ensure that proper health care is being provided. You've got actuary, and that's the hardcore math. That is the group of individuals. They're the mathematical gurus of a health plan that are determining rates, determining contract structures, working with state and federal governments to ensure that the claims were not only the health plan was properly reimbursed from government agencies for those healthcare goods and services that we were providing via their members, but also that things like premium pricing was accurate, that the health plan was being accurately reimbursed from government agencies to ensure that we were providing at a viable cost, at a proper cost, those goods and services to the covered lives that were within that particular program. You've got human resources, and human resources, it's kind of a I guess kind of a somewhat of a different animal. Whereas operations, medical management, network management, payment integrity, with the exception of the fraud work we were doing, but most people in payment integrity had access to, and others within the organization had access to the information that we were providing in the data warehouse. You had internal audit, risk management, legal, human resources, HR had their own sections within that information warehouse, because they had, especially legal, internal audit, HR, they deal with some really sensitive information about not only members, but internal employees within the health plan. So they had, there's you're talking about it at that point, it was limited access. And so they had their own special limited access to their information. And then lastly, when it came to the data warehousing, you had information technology. They were the individuals that made sure that that information warehouse kept humming along, made sure that the information warehouse contained all of the relevant information that it needed, ensured that when individuals went in to access information out of the warehouse, that that data was accurate. And by using that accurate data, the individuals accessing the information warehouse had a confidence level that the information they were going to extract was going to be accurate and be viable for the corporation. Just to quickly go through, for at least from the payer side, especially if you decide to go into kind of the analytical side on the payer side, there's a lot of sample reports that you'll become familiar with. One report that floats around within a lot of health plans is what they call affordability, and it's the health plan's attempt to identify opportunities to what they call maximize the benefit to the covered population or to the members, and also opportunities to minimize the healthcare expenditures that not only the health plan would occur, but the members could potentially occur. So you were looking at affordability, and the way it was set up, it was team meetings, and at least in Blue Cross Blue Shield, it was payment integrity, it was actuary, it was network management, it was medical management. They had some legal representation, had some risk management representation. IT would sit in on it because we needed somebody to answer the technical questions. And basically, we were trying to identify programs that were going to provide a better outcome for the covered members, and also to minimize the healthcare expenditures for both the health plan and the member population. So that's what affordability did. We also, and I was involved in kind of the healthcare trend reporting, the pharmaceutical reporting, what you call new modalities and technology. And basically the healthcare trend report, we looked at each year, there was a goal set within the corporation that said, starting in January the 1st that next year, we were going to, in the terminology, we were going to bend the healthcare trend. But if you were going to reduce healthcare expenditures over the coming year by 1%, 2%, 3%, whatever the goal was, then you were going to bend that healthcare trend by that percentage. And you looked at services. Again, it was affordability information fed into that healthcare trend report. And the healthcare trend, as its name implies, you are managing the trend, or you are managing healthcare trend month by month from January the 1st until it came around into December the 31st of the next year. And you were managing it toward that trend number of 1%, 2%, 3%, however you're going to bend that trend. You were looking at things like new pharmaceuticals that were going to hit the market. You were looking at new modalities in healthcare. You were looking at technological advances. Were there technological advances that were going to cost a lot more money? Were there new pharmaceuticals that were going to cause the healthcare expenditures for a given year to explode? So a lot of the information and a lot of analytical brain power went into developing that healthcare trend report, and that healthcare trend report was circulated throughout the company, sharing information so that if it was something that medical management need to focus on, they had the information. If it was network management, they knew they had to go in and renegotiate contracts. If it was something on the legal side of the house, they knew they had to have a heads up on what was going on. So healthcare trend reports are extremely important at all the payer side of the healthcare of that financial coin. You had kind of a combination in medical management. You had case management, which case management is basically, and I think I mentioned it earlier, they assign nurses to high dollar cases, either individuals in a hospital that are getting discharged to home, or individuals that may have a significant deterioration in their health status, so that they have to be managed maybe in a different way than other patients have to be managed. Authorizations and referrals. You have some healthcare goods and services that are consumed by your covered population that have to have authorization and referral before those healthcare services can be provided. So all of that comes under medical management, case management, authorization, referral, all rolls up under medical management. You have HEDIS, which it's healthcare effectiveness data and information set. And it's by the NCQA, and it's a measure of performance by health plans. And HEDIS results drive a lot of success on health plans, especially when it comes to individuals or companies deciding that they want to choose a particular health plan to provide covered services for their members. So these HEDIS reports, and a lot of effort is expended within a health plan to ensure that the HEDIS reports can be as accurate as possible, and take that information in that HEDIS report from one year and use it to improve the health plan performance over the next year or the next coming years. You've got network adequacy. Network adequacy is a network management report, and it determines areas within the, the business coverage limitations that a health plan has within a particular state. And network adequacy provides the metrics for not only members, but state and federal agencies, and actually local agencies, as to whether the health plan has a sufficient network to provide goods and services to a covered population. It will provide information like number of hospitals and the number of services the hospitals provide, and what types of services, and the number of primary care doctors, the number of orthopods, the number of cardiovascular surgeons within given areas. And it can be either calculated based on number of providers per 1,000 members, or it can be based on a more rigorous calculation, making assumptions on how many of your members a provider can see in a given day. And so using that type of information, you can extrapolate, a health plan can extrapolate, or a payer company can extrapolate how many members they need, or how many providers they need for a given number of members by specialty. Network adequacy reports get extremely complicated. They're extremely complicated to calculate and to ensure the numbers are right. But at the end of the day, you have to have a health plan has to have enough members in a given geographical area to service the number of covered lives that they have within that health plan. You've got population health. Population health is, you're trying to, and at the end of the day, health plans are focused on trying to maximize the health status of the population. They want to ensure that their population will live as long as possible and be as healthy as possible over the number of years that they're alive. And that's what we're talking about, population health. They're pulling out uh, different subsets of population health and managing those subsets of population health to ensure that the covered lives, or to ensure that the members covered by that health plan are being provided the scope of services they need to live a long and healthy life. You've got reports, call center reports, customer service reports, claim processing reports, member retention reports. These are all kind of falling under that, what I've always considered kind of an operational type of category. How many calls are coming into the call center? How many of those calls are being handled with a accurate response the first time? You've got customer service. Individuals are calling in and asking questions about the health plan. Is customer service, first time, every time, answering the questions with accurate information? You've got how many times on the claims processing, how long it takes to process the claim. What's the accuracy rate of processing those claims? How many of those claims have to be reprocessed? Member retention. How many members that you enroll in, we're in 20, drawing a blank on what year this is. Where it must be in 2024, I guess. Yeah, we're in 2024, I guess. So, and we're in 2024. So how many members that we enroll in 2024 will we retain as we roll into 2025? So I don't know. It's just there's a lot of call center, a lot of customer service, a lot of claims processing and member retention reports, because all of this information goes together, and these referred to as operational reports, they go together to drive customer satisfaction and to estimate the potential number of members that a health plan will retain from year to year. And then you've also got what you call Section 111 reports, and you've got HIPAA, eligibility wrapper, or HUE files, and these are type reports that the health plan uses internally to ensure that Medicare eligible individuals, or individuals with ESRD, or individuals with significant types of issues, are managed properly and are receiving the type of care that they need. So extremely important, the HUE files and the Section 111 files, from the aspect of managing an elderly population, or a population that needs significant types of healthcare benefits. And then lastly, some of your, some of your sample reports that are coming out of a payer are employee metrics. And every health plan goes through on an annual basis, satisfaction surveys with the employees, how the employees think that the company's doing, what the company can do better to ensure that the employees are functioning at a level that will ensure success in the long run, or in the long term, for not only the employees but the health plans. And a lot of this information is captured in surveys. You have most health plans I work for, you have quarterly surveys, then you have an annual survey, and HR is working with the analytical shop to put it together. And actually sometimes on some of these employee metrics, the health plan, to eliminate the perception of bias, will go outside to a third-party vendor that comes in and does all the work for them. Extremely important when it comes to managing a health plan, because you want to, as the senior management team of a health plan, you want to make sure that you've got your finger on the pulse of that health plan, that the finger on the pulse of that payer association, or that payer organization, to ensure that you're doing an accurate job of not only managing the healthcare services you're providing to the members covered under the health plan, but you also want to make sure that you're providing a workplace environment that is conducive to uh, your individual employees working there, to ensure that they enjoy coming to work, to ensure they're doing the best job possible, and to ensure that they are providing the goods and services to the covered population uh, that you have enrolled with the health plan. And that's going to wrap it up for kind of the, the payer uh, part of that financial coin. The next time we get together, we're going to spend a few minutes talking about um, the flip side of that financial coin, talking about the provider side of the financial coin, and how they use information warehousing. And you'll find that while some of the concepts overlap, or some of the concepts are familiar or similar to each other, you're also going to find that when it comes to the provider side of the house, um, there's a lot there may be a lot more nuances, and there may be a lot more um, pieces of information floating around that has to be aggregated, especially when it comes to managing with the health plan, with the payer. We're concerned with accurately paying the claims, accurately providing a provider network that can service and provide the healthcare goods and services to the members. And then as a result, take those claims that come in from the members and ensure that the claims are processed correctly, and that everybody is paid, both the providers and the members, if they need be, are paid appropriately. We need to make sure on the payer side that all of the government agencies are provided the information that they need. And so it's just a little different. It's a little different approach to kind of one side of that financial coin. That's why there's two sides to the financial coin. You've got the payer side and you've got the provider side. And I think you'll start to understand that as we move into the next round. And again, we're going to be talking about um, the aspects of what goes on when it comes to um, the provider side of the house. And with that, we're going to call it a day and talk to you soon. Thank you.